commento con le vostre relazioni che sono state anche molto interessanti.
Scusi, possiamo dire che ieri alla clinica pediatrica di Bologna per la prima volta sono stati introdotti dei robot per fare appunto sia robot di bambini appena nati, sia robot più grandi, proprio per abituare i medici a cioè lavorando sul robot per abituarli poi a lavorare sul bambino in carne ed ossa. Quindi mi ha molto colpito questo, Bologna ieri la prima volta. No, vabbè,
Ecco, se aprite il giornale di oggi, voi vedrete che ieri alla clinica pediatrica dell'ospedale Sant'Orsola, che è una clinica universitaria, per la prima volta sono stati introdotti dei robot per fare esattamente quello che fanno all'Università di Illinois. Mi sembra che siano 4 robot, 2 piccoli di bimbi appena nati e 2 appunto di bimbi più grandi. Può darsi che domani nella visita a Sant'Orsola riusciamo ad andare a vedere anche questi robot.
Bene, la parola di studenti.
I apologize, I'll be standing up and talking because my brain doesn't work when I'm sitting down. Can you indulge with me for a little bit? How many of you have smartphones right now? Almost everyone, I hope. And how many of you have medical apps on your smartphone? Okay, great. Enthusiastic room. I just want you to write down or think about how many doctors are there in Sierra Leone. Sierra Leone is a country in West Africa, and their population is 6 million people. I want you to just think about or write down your best guess as to how many doctors they have in the country. And we revisit the question when we're talking about all of these things. So good evening, I'm Mayank Kale. I'm studying computer science engineering at the University of Illinois. And I'm one of the co-founders of Bling Technologies. This is my other co-founder.
My brain works best when I sit down, so I'm actually a little too tall for the microphone. But I'm Kyle Hirschfelder. I study molecular biology and computer science, also at the University of Illinois. Before we get started, I'd also like to thank everyone for coming out today and sticking around. I know it's been a long day. There's been a lot of awesome talks and information. I'd also like to give a special thanks to Professor Paul Magelli, who has helped us with our travels and organized this event. We're honored to be here.
Let's get started. So I visited a nonprofit in India called by the name of Search this January, and that completely changed the way I thought about healthcare. You know, Search was founded about 30 years ago in a very remote and rural area in India, in India's forests, where the infant mortality rate was 20%, 1 in every 5 infant, right? And over the last 30 years, the infant mortality has gone down to 3% now because of their efforts with local villagers and tribals in 124 villages. It's funded by a foundation and it delivers free healthcare to 100,000 people. And you would be surprised as to how bad the hospital and patient model works in developing countries. Because of extremely large populations, extreme poverty, and very little infrastructure, the hospital patient model, that is, asking patients to come to a central place to get any sort of medical care, seems to be an impossibility. India is also short of 4 million doctors. 4 million, by the most conservative estimates, they're short of 4 million doctors. So what can a country do to bridge this gap? You know, people in villages or rural India don't have the basic models of healthcare. They don't understand what diseases are. And so how can we design a future that can allow us to overcome the gap created by a lack of 4 million doctors? Well, Search has done exactly that. I mean, 30 years ago, they were pioneers of the community health model in India. So they don't have doctors. What they do is they use people called community health workers. These are locals from the villages, so from the 124 villages that are with a radius of 100 kilometers. They have locals from each village who are probably high school graduates, right? They're only educated at high school. They take these people and they train them for years and years to diagnose and administer drugs for 22 diseases that they have identified. Now, these aren't diseases like breast cancer, but these are diseases that affect the population in general. You know, like malaria, pneumonia in infants, and things like that. And so, because the local populations have no idea about what a disease is, it becomes very important for us to treat symptoms for these kinds of cases. And so the male health workers are present in each village and are responsible for diagnosing and administering these drugs for 22 diseases. There are also female health workers that have been trained since so many years who are completely in charge of neonatal care. You know, more than 60% of India's population lives in rural areas, and a huge amount of the pregnancy or deliveries happen at home. They don't happen in hospitals because there are barely any roads or barely any infrastructure or public health services. And so these ladies who have only graduated from high school are taught how to deliver babies, are taught how to care for pregnant mothers, are taught neonatal care so that they can administer great health care to these pregnant mothers in remote areas of India where there are no hospitals. Before they can administer this health care, they have to have information about these populations, right? So the form you see here is actually a form for census data, right? This is a form in the local language, and this is filled out for each family that resides in the village so that they have basic information about these individuals. So Search has recorded forms for 100,000 people across the 124 villages. And they keep these records so that they can use them to administer healthcare to these patients. These forms are physically checked and transferred. What that means is that they're written by paper, they're written by hand by the community health workers in the villages. These are then checked and they're transferred back to the headquarters where Search has a hospital that delivers free surgeries and other kinds of free healthcare. The turnaround time is about 8 days. So it takes about 8 to 10 days for each form to get back to the headquarters. Now, the reason Search has been so successful is because they are primarily a research organization. They're primarily people or scientists. The co-founder is a graduate of Johns Hopkins, and they're scientists trying to study how to better administer these solutions in these areas. And so getting this kind of data is extremely important, and doing it in a short amount of time is going to help them administer much better quality of care for lower costs. You can imagine one hospital in one place having so much trouble with paper records and digital records. Imagine 124 villages trying to transport and coordinate all of these paper forms and having them shipped to a headquarters where they're then processed. You know, the headquarters has 5 employees working full-time, and their only job is to type. They take these forms, they translate it into code, and they type it into a computer so that it can be processed later as digital health information. This may seem backwards, but a large amount of clinics, and even in the United States, are still using paper records. And so, really being able to make this process easier for these villages, for these 124 villages, becomes vital and very important to be able to deliver healthcare to the new populations of the world. These are some of the more defined problems that are being faced. You know, there is lack of comprehensive data. You can only record so much on healthcare, on notebooks, on papers, and so there's a lack of comprehensive data that will allow the health workers to deliver healthcare. There's a loss of data. As you can imagine, you know, there's a loss of data in notebooks. Paper gets lost, paper gets torn. You know, you can destroy paper records, and so there's immense loss of data which is not checked. There's limited resources and knowledge. What that means is that these health workers who are not very educated don't have the resources and the knowledge to be on the field and be delivering good health care, because they cannot carry around large notebooks or large books or textbooks because, well, they don't understand very much, but also that it's very impractical. There is no outcome data, meaning if they deliver healthcare in a village, there is no way of knowing what happened to the patient after unless you go there physically and check up on them. There's no outcome data to learn from, so you can revolutionize the way you do your processes. There's very little internet connectivity. On the field, it becomes very difficult to transfer data because there's no internet connectivity in these villages. And since India has more than 350 languages, it becomes very hard to design software for these kind of locations. And there's also large amounts of illiteracy. And illiteracy meaning someone who's 50 years old may have been to school, but may have forgotten how to read and write because they haven't done it for the last 30 years. And so with problems like this, how do you deliver healthcare when they're short of 4 million doctors? This is the sort of the problem or the white space that we have identified. You may say that there exist online form builders, that you can just build forms for this kind of operation and collect data using phones. But they're very primitive. They don't enable healthcare workers to necessarily give better care. All they're doing is collecting data. The second more complex part are electronic medical record systems. Most doctors complain about using them. So you might imagine EMRs are very impractical to be used on the field to be able to collect this data and get healthcare information about these patients. And that's where we come in. We want to study this white space, this problem, and see if we can design a technological solution to this problem that gets rid of the costs, that overcomes language, that overcomes the issue of connectivity, and that provides ease of storage for this data so that we can deliver better healthcare for the populations of the world. We like to say that 40 euro tablets can change the world. The tablets that we can buy today for 30 to 40 euros have more computing power than the average computer a few years ago. It's incredible what you can do with these tablets today. And with the touchscreen interface, it's completely revolutionized the way people interact with computing power. Our vision is to build a complete system for community health workers so that they have control over their data, control over their operations, and they can do their job. We want each community health worker to have an overview of every patient in the village. These community health workers live in the villages who have populations of maybe 4,000 to 5,000 people. And so if the community health worker has a mental model of how a patient is or how a patient has been for the last few years, they can predict, they can prevent diseases, they can do their job in a much better way if they have this overview or mental model of the patient. We also want them to have control over the care provider, have control over the drugs they're administering, have control over the processes that they're going through. And more importantly, we're going to use the tablet to enable learning so that the community health worker can really learn on the field, and every day can be a new experience for this person who's trying to save lives on the field. I'd like to hand it over to Kyle to talk about the technology.
Hi, okay, so right now I'll break it down the current workflow. There are village health workers in each village right now with the tablets, and they go around and they collect all the census data. They store it locally on the device, there is no need for internet. And then every couple days, a supervisor who curates the data, makes sure the data is pure and clean, goes out to each village and connects the data from the tablet and retrieves the data from the villagers, the village health workers, excuse me. But like Mayank mentioned earlier, connectivity is a problem. We're in rural India right now. There's no Wi-Fi, there's no cell towers, Bluetooth is not effective in this case because it's slow to pair So we have modified an existing technology called Wi-Fi peer-to-peer, which allows for seamless data transfers. It's very fast, it happens behind the scenes, and it allows for data transfer in areas with no connectivity. So then the next part of the workflow is the supervisor returns to the headquarters, and with just the click of a button on their tablet, they can push all of the data they've collected, all this aggregated data, to the server, and it happens just like that. And the nice thing, and we heard a bunch of talks this morning, or a couple talks on data security and data protection, is that our servers that we deployed right now in India are local. They're physical servers and they're not connected to the cloud. So these people in India, they are unfamiliar with the technology, the cloud. They want to make sure all their data is secure. So we provided this by using a physical device that only they have access to. We have a video that'll show kind of the workflow and the use of the app here.
This is just a small demo so you have a sort of fair idea of what we're actually talking about. This is the census application that we have built that we just recently shipped to Africa. But as you can see, the healthcare worker has complete information about all the families that are living in this village. They can go to forms. They have a way to access census forms where they can add family members and family heads and house information, so they can record all of the census data that otherwise took them 20 minutes, 30 minutes to record. These are the kind of forms that can be filled out very quick, and this is language independent. We can do this in any language we want because the data on the back end is only stored in binary zeros and ones. And so you can retrieve it in whatever language you want, and you can display it in whatever language necessary, overcoming the problem of 300 plus languages in India and way more languages across the world. Here I'm trying to add a member to my family, and after forming this sort of census database, I can use each member as a patient. And so if he comes to me complaining about a fever he has, I can go back and see what kinds of previous diseases he's had. I can see what kind of house he lives in, where the water supply comes from, what the health conditions are, what the sanitary conditions are. This becomes important context to be able to make decisions on how to administer the healthcare on the field. Here I am just trying to fill out information for the census form. Again, this can be filled out in any language, and this is very comprehensive. And all of these are necessary questions that may be important for us to realize what specific kind of disease the person might have. This is it's so easy to save the forms, and you can go back to members, and there we've added a new member, maybe with the same name. Depending on the area we're deployed to, we have different ways of breaking ties of whether people have same first name and last name and things like that. So that's just technicalities again, and you can view this information anytime you want. This is a very limited preview of what we've deployed, because this is only the census portion. We've built a medical portion on top of this.
Okay, so continuing on the technological aspects in the workflow, as Mayank said, we have handled the language barrier, which is a huge issue around the world, around the globe, and especially in India, where there's so many different types of different languages and dialects. We've created a system that they can just enter in basically a language and it works. We've solved data storage issues by reducing the amount of paper forms they have now. They have a tablet with so much space. We're trying to really grasp how powerful these tablets are. I know it's been mentioned that these very inexpensive devices have so much power behind them. We're really trying to embrace this. It's inexpensive development and support. So we have written most of our backend in PHP, which is a very prominent language, coding language, that allows us to reach out to offshore developers if need be and get help and support. And if they need to do the same, they also have access to that. And the geographic representation of health data is on another slide. I will explain that. As Mike also explained, the binary compression algorithm was a way for us to reduce the bandwidth of data transfer on top of our Wi-Fi peer-to-peer system. So originally, these tables they were filling out, these census tables, had 164 columns. That's a lot of data to send when you have no connection. So we developed this binary compression algorithm which allows us to reduce the size of the columns from 164 to 20. And so that we can efficiently and effectively translate the data and transfer the data where there's no connection. And it also allows for compact data storage. We explained that there are a lot of patients that we're collecting this data from in these villages, so we have to be able to stack all that data very effectively. So here's an example. This is an early example of our GIS, our Geographical Information System. And what it allows us to do is provide them with something they've never seen before. It is a bird's eye view of healthcare, and it allows them to pinpoint each village that our software is deployed in, and with just the click of each village, it opens up and it populates these tables with how many people and villagers are in that village, how many pregnant mothers, which we went on to say is very important to know, recent emergencies. We introduced a system where they can track all the medicines so that they can be efficient and effective with where they're delivering certain and particular medications. And we want to really isolate any emergencies so that if, say there is a disease outbreak in one village, we can identify early on and have a first response to which village has a disease or some sort of effect and get there immediately and figure out what the problem is. Another area of interest is if two villages are near each other and they answered on our forms that they retrieve their water from the same well or the same stream, and they also had a similar outbreak in disease, we can figure out then, okay, maybe because they all answered that they get their water supply from a similar area, that the water is contaminated. So it allows for another dimension of healthcare and observation of where these outbreaks are coming from. It allows us to get there and save more lives. So when an administrator logs on to our back-end system at the headquarters, like I explained earlier, it's a local system so that there's no cloud interaction. This is what they're presented with. It allows them to add more family members, curate and edit any data, but more importantly, one of the biggest things we want to empower them with is being able to look at the data, query the data, and publish papers and actually improve healthcare based on the data. So take a predictive healthcare approach and learn from the data they've entered how they can improve the healthcare that is delivered to these villagers and save lives.
So we started building this software in about May of 2015. And in about 8 weeks, we wrote somewhere close to 65,000 lines of code because I flew to India in August, where we actually deployed our software with the search organization. So it's an ongoing beta test. You know, it looked completely different from the way we had designed it, because when I took it to India and we deployed it, we found that it was taking someone who had never used a tablet before, it was taking them 20 to 30 minutes to understand what's going on and start recording the census data. So we worked with them, we used principles of empathic design, and over 12 days or 15 days, we remodeled our user experience watching them use the software. And by the end of it, we could hand our tablet to someone who had never seen a tablet before, and they would be up and running with the software in 5 minutes. In 4 to 5 minutes, they could start using our software, go to houses, and start collecting this data. And so it was an incredibly valuable experience, and we've been developing this software ever since, and I will be going back to India in December for further implementations. And so we have deployed 5 tablets and 2 servers. More information about how much our deployment has impacted yet. Over the last few months, we have about 60,000 records on the system. So out of the 100,000 people, we've already collected about 60,000 records with the help of search. And we have reduced the cost of acquiring this data by 55%. And so that allows them to deliver twice as much healthcare in the same amount of cost. It has also reduced time of acquiring data by 6x. So now you can collect this data, and these are conservative estimates. You can collect this data in 1/6 of the time. And so you have a lot more focus on actually delivering quality care rather than struggling with collecting the census or health information. One of the health workers at Surge said this to me once, and I was completely floored. You know, this is what makes it worth for us to do this kind of thing. He said, "This brings me happiness and excitement to do my job. This computer thing is very intelligent." You know, he's been doing this for 20 years, and he said it brought him excitement and happiness to do it this way. You know, they got it. They embraced this new technology. You know, they thought it was intelligent because it was talking to them. It was telling them what needs to happen in order for them to take care of people they like to take care of. And so I think it's been our mission, and this has reinforced that mission of really enabling people to deliver better healthcare. Okay, what are your guesses? Can someone shout out how many doctors you guess were in Sierra Leone? Can I get an estimate, please?
60,000.
60,000?
I don't know.
There are 120 doctors. That's an actual number by the United Nations. There are only 120 doctors in Sierra Leone. And for a population of 6 million, that's not right. You know, there's something wrong with that. And you cannot go around planting more doctors. You know, we have to get out of this model or this limitation of who a doctor is, and we have to see what the end goal is. And the end goal is to deliver healthcare and to take care of people and to save lives. And so we really need to train people. We have to train sort of micro doctors and community health workers and provide them with all the technology we can to be able to do their job better. You know, we're proud to announce that this is our first week of a pilot in Sierra Leone. One of our professors from the University of Illinois has taken our software to Sierra Leone right now, and she is piloting our census software. We haven't heard back from her yet, but we're hoping for good news when she comes back. We're associated with the Najala University because they're one of the premier delivers. They deliver healthcare primarily to most of the population near Freetown and in all of those areas. And we will be focused on neonatal care to reduce the infant mortality. And we will be also focused on epidemics. So there's transparency of information, and so we can prevent epidemics like Ebola from spreading further in the future. So what is next for us? You know, this is one of our favorite slides because it keeps us going. We talk of the digital health ecosystem. You know, what's surprising is that when we deployed in India, someone who had never seen a tablet before embraced the technology faster than my dad's cardiologist in Mumbai when I was trying to talk to him about technology. And so that goes to show that we really need an ecosystem where all the stakeholders, whether it be the patients, the health seekers, the doctors, the community health workers, and the people doing research, I mean, all of the speakers today have talked about this, is we need them to interact with each other so there's transparency of information and there's a clarity of knowledge that's going to happen in this ecosystem. And we want to be able to create these digital micro-doctors, you know, almost enabling any person who is sufficiently trained in delivering this kind of service to be able to become sort of a micro-doctor and sort of administer quality care to populations who have no access to health infrastructure whatsoever. One of our other missions is to aggregate the world's community health knowledge. You know, there's so many community health organizations in corners of the world that are generating tremendous amount of data and learning and knowledge that is not being aggregated today. You know, That's sort of one of the things that drives us, is so we can have a platform to learn from this global knowledge. And so if a organization in Brazil learns about something, or if they're doing a study and if they have results, they have a universal platform to be able to share it with anyone across the world, so that another organization in China could learn from it and not make the same mistakes. And this can be extremely powerful in certain situations where there's limited infrastructure, limited resources, and limited knowledge again. And we want to be able to predict future trends for a healthier population. I mean, we don't just want to reduce costs of care or of curing people. We want to be able to prevent and predict these diseases, so we not only reduce costs, but we have a healthier population. And why this is important for every country in the world is because most of the next generations and the next centuries working population is going to come from these developing countries, where more and more people are coming out of the poverty line and are contributing to society. You know, this is a much bigger issue than just healthcare in India. This is about how can we have a better global healthcare system that is going to allow for further human innovations and inventions and betterment of human society, because a healthy population is the basis for each of this. And I have one last slide. You know, you must be wondering why we're called Blink. Well, in the last minute or so, most of you blinked about 16 to 20 times. You know, you didn't realize it, but you guys blinked 16 to 20 times. And blinking serves a purpose. You know, blinking is doing its job. Blinking has some role in your body that it's fulfilling, but it's non-intrusive. You know, that's the beauty of nature, is that blinking, or this technology of a blink, is not intrusive. You're not consciously doing it, yet it's serving its purpose. And the philosophy behind every single technology that we want to build is that it should be invisible to the user. You know, it should not disrupt. It should be creative. It should be so invisible that it does its job, and it does its job well, but the user does not realize it. You know, the user will embrace this technology as part of himself. And we're not trying to replace humans by computers. We're trying to enable them for caring for the populations that they care about. Thank you so much. I'd like to thank Sylvia and Massimo.